and analysis. So there are some good papers in the literature with regards to summarizing some of this. It's important that I think in the past, in the initial look at contouring, a lot of data was looked at like in terms of just gross volume and center of mass. But as you can see here on the left side, things with similar volume can actually have totally different shape, but also totally different center of mass and totally different anatomy. So essentially, it's important to know that, like, although you can look at volume as a parameter, it's pretty simple zeroth order analysis. And so other more precise metrics have been used, including the Dice coefficient, looking at the amount of overlap between volumes, the Jacquard index, which is similar to the Dice, and other types of volume overlap indices and kappa statistics, looking at trying to have a better handle on like how much overlap there is, or how much agreement there is. The other advancement in 2004 was a publication by Warfield and his co-workers. Basically, this is an algorithm that will take multiply contoured data sets and actually come up with what this computer algorithm will consider as a consensus contour. This algorithm, the paper that underlies it is quite dense, and many of us don't fully understand the algorithm who are not mathematicians or physicists. But essentially, this is a validated approach to deliver, consensus contours based on multiply contoured data set. This staple algorithm has been consistently used by RTOG in terms of creating consensus contours for their atlases that I previously mentioned. So this is a commonly accepted algorithm to actually create these types of consensus contours. So with that background, I want to just launch into a couple of our research questions, and then I'll be happy to take any questions at the end of our session. So our research questions here in London were that, can we improve upon some of these traditional point or volume-based contouring assessment metrics that I mentioned already? And can the use of a consensus-based penalty metric be created in order to guide educators and other individuals in terms of our contouring teaching interventions? So are there ways that we can actually give feedback to clinicians and residents in a very prospective and standardized way in order to help guide basically to guide improvement in contouring? Can these penalty metrics that we're going to be talking about, can they be further improved in the future by looking at the interaction between contouring variability and dosimetry? I have a little bit of preliminary information regarding this, which I'll show at the end of the talk. And can penalty metrics be used in other contouring evaluations other than looking at residents? So things such as autocontouring, clinical trial credentialing, and physician evaluation, or CME. And the other question that we had was, can we define new methodologies for assessing these contours, given the fact that there is no true gold standard, and the best that we have is the staple algorithm, which gives us a representation of the truth. So for our first project, we actually developed something called the crisis penalty metrics, and crisis is the critical structure intercomparison of segmentation, so that's what that stands for. And what we did is we basically did a Delphi study, and a Delphi study means it's a consensus building approach within our institution, looking at 5 different physicians who are experts in various areas, and to try to come up with penalty metrics that we would want to assess our trainees who are contouring organs at risk, and when we compare it versus experts with regards to these organ at risks. And so we use the structure software to actually build these metrics, and they're voxel-based, as Neil had mentioned previous. And we wanted to come up with these or consensus-defined penalty metrics to score new contours. And then we wanted to look at the feasibility and utility of actually using these penalty metrics in an educational intervention itself. And so this was part of a weekly resident rounds, and we actually did a whole bunch of them in a row over a 6-week period of time in order to assess these new penalty metrics. So we calculated these penalty metric scores, and we gave these to the clinician to direct the intervention with regards to teaching, and with the overall goal of trying to improve contouring from the resident perspective. So you've seen part of this before in Neil's presentation. Essentially, we have cases where we are using structure to try to define what missing contours are and what are some missing voxels are and where common voxels are and where extra voxels are. Everything in red is extra, everything in green is common, and everything in blue is missing. So, as I mentioned before, there are these other parameters that could be used to look at comparison of contours. So why are we interested in penalty metrics? The reason why is that we believe that not all voxels should be necessarily considered equally. So when you have a spinal cord, if you under-contour a spinal cord or a brain stem, we think that should be penalized differently than if you over-contour a bladder, for instance. So we think that not all OARs are the same, and not all deviations from standard contours are the same. So that's why we like the structure program. It allowed us to actually do differential penalty metrics depending on what we define a priori as important differences. So here, as an example, you can see an example of a metric where, if it's under-contoured, that there is sort of a quadratic or exponential contour penalty metric on the one end, whereas if it's over-contoured on this side, that it was more of a linear and more gradual. It's just an example of one potential penalty metric that can be created. So when we went through our discussions, the two things that we were sort of front and center were we wanted to have an understanding of the radiosensitivity of the organs at risk that we were talking about, and also the clinical impact of an over or underdose with regards to those contouring structures. Also the clinical impact of over-contouring and under-contouring. In part, we actually went through the Quantitech data. That's a series of publications from last year in the Red Journal that actually talked about these two issues, about over and under contouring in terms of dose volume histograms, but also radiosensitivity. So ultimately, what we ended up doing was, on the left, we actually created the crisis penalty metric system, where we as a group came up with a consensus of what we thought reasonable forgiveness regions were, either for under or over contouring, and then what types of linear and or exponential penalties should be applied to over and under contouring, and how severe those contouring penalty metrics should be. And that could range from 0 to low, moderate, and severe. So on the left, you can actually see that we created this crisis penalty metric system, which can be used with any potential software. But what we had to do was actually then translate that to structure, which is on the right. Using a whole bunch of Unity functions, we were able to then convert them into essentially a whole set of structure penalty metrics that can actually be then inputted into the structure program. So this is an example of one of the penalty metrics that we actually ultimately used. And this is for a parotid gland. You can see here parotid. And so we decided, based on our discussions, that if it was slightly under-contoured or over-contoured within a millimeter, we accepted that as forgiveness. And as the parotid became under-contoured, there was an ever-growing linear penalty. And actually, as it was over-contoured, we put a ever-growing exponential penalty. One of the discussions that we had was that we didn't like under-contouring because we didn't want there to be hot spots left in the organ at risk, but also we didn't want to have people over-contour significantly because that would actually drive your DVH down, and there might be problems with IMRT optimization. So ultimately, this was the consensus in terms of this parotid, and then we have other ones for all of the Quantitech structures. One of the other things that we put in our manuscript with regards to this is just a starting point. Other people may feel differently about penalty metrics with regards to various organs at risk, but ultimately we did get 5 physicians to agree on a set of default penalty metrics. So ultimately what we did was then we actually had a series of cases that actually spanned all of the organs at risk. We provided information to the resident with regards to what we expected them to contour, and even specifically protocols that they should be following. And essentially we then compared their contours versus the clinician that was teaching their contours. And then we provided feedback to the clinician with regards to the penalty metric scores here. And then after the resident had their teaching session, they were given up to a week to actually then change the contours based on their teaching. And then we did a second structure analysis with regards to whether or not